Thank you also for joining us today. I'm very excited to give this update on cancer research and clinical care. The primary focus for cancer research at this time is precision medicine, and the goals of precision medicine are to create targeted therapies for individual patients. The key elements to developing these targeted therapies include better techniques at detection as well as genetic analysis. For breast cancer, for many years we've known about subtypes of breast cancer, and in the two areas we look at primarily have been hormone receptors and HER2 receptors. And these studies are done by the pathologist when a cancer diagnosis is made. They stain the cells to determine if the tumor is sensitive to estrogen, progesterone, and HER2. This has allowed us to develop many targeted therapies for these particular subtypes. But we know that there are many other factors that influence a cancer's biology. And the control center of the cell, the DNA, has genes which are made up of chromosomes, and these are important in terms of controlling the cell. We've learned that there are certain types of genes which are called oncogenes, which can allow a cancer cell to develop, and there are also tumor suppressor genes, and these genes can help to inhibit cancer cell growth. Much of what we've learned about cancer genetics relates to hereditary cancer subtypes. And for breast cancer, BRCA1 and 2 have been the two most common that we've studied, and these are examples of tumor suppressor genes. BRCA1 and 2 are important in DNA repair, and when DNA repair doesn't happen correctly, that allows mistakes to be preserved and cancer cells to develop. Recently, in the last year, 2 new drugs have been approved for breast cancer related to these DNA repair genes, and these drugs are called PARP inhibitors. This is a slide just demonstrating how scientists developed PARP inhibitors for patients with BRCA gene mutations. What they've learned is that there's one pathway that's important with the BRCA1 and 2 genes, and then there's a second pathway, which is a double-stranded DNA pathway for repair. When one pathway is defective, as in BRCA1 and 2 mutated cancers, that allows the cells to grow abnormally. With inhibition of the second pathway, that prevents the cell to survive. If both pathways for repair are knocked out, the cancer cell can't survive. And so scientists developed PARP inhibitors to block that second pathway and enhance cell kill. I've shown here the 2 drugs that were reported out last year in the New England Journal of Medicine, talazoparib and olaparib, as 2 PARP inhibitors which were studied for patients who had BRCA gene mutations. These drugs were studied compared to standard chemotherapy that we use in the treatment of advanced breast cancer. With both drugs, the PARP inhibitors worked better than standard chemotherapy for patients who inherited breast cancer mutations with BRCA1 or BRCA2. We know that there are other types of mutations and that PARP inhibitors might be helpful for patients not only with BRCA1 and BRCA2 mutations. When we talk about hereditary breast cancer, we're talking about germline mutations. Patients were born with those gene mutations and inherited those. A cancer cell, when it divides, it can acquire mutations. Those are referred to as somatic mutations. And there are ongoing studies to determine if PARP inhibitors could be used for patients that acquired these mutations. At Hopkins, we have the IMAGE-2 trial, which is a trial led by Dr. Stearns. In this trial, we look at the genetic analysis of the breast cancer, not just what the patient inherited, but those acquired mutations. And then once we see that genetic analysis, we have the Molecular Tumor Board review that and determine if there are additional targeted therapies that could be used for that patient. The HER2 receptor and hormone receptor subtypes are still crucial for developing new targeted therapies. And this last year, many advances occurred in HER2-directed therapy. The traditional approaches with HER2 cancers have included the antibodies that bind to the surface of the HER2 receptor, and that includes trastuzumab and pertuzumab. Two new drugs that work in a different manner have been reported out in the past year. These drugs work on the inside of the cell, and those drugs include neratinib and tucatinib. What's different about these cells is they turn off the pathway on the inside of the cell rather than binding to the receptor as an antibody. And these are oral medications, and they work differently and potentially can offer additional benefit beyond trastuzumab and pertuzumab. Neratinib was demonstrated to improve outcome after standard therapy had been given with trastuzumab. The unique factor that these are small molecules has raised the possibility that these drugs could have access to brain, whereas pertuzumab and trastuzumab have less activity in those areas. This is a diagram showing how the neratinib and tucatinib potentially interact with the HER2 pathway and activate it. The HER2 CLIMB study was reported at San Antonio in December. The HER2 CLIMB study demonstrated that when tucatinib was added to standard therapy with trastuzumab as well as capecitabine, it had a dramatic improvement in control of the breast cancer for patients with advanced disease. And for the first time, this study also demonstrated that it was active in patients who had brain metastases and showed improvement in control of brain metastases, which is very exciting for patients. This study was reported, and we're hopeful that it will soon become available for our patients. Another approach for HER2-based therapy relates to another combination, which is referred to as a drug-antibody conjugate. This is a drug that is developed in the lab, and it involves binding the antibody trastuzumab to a chemotherapy drug. This drug there's one drug that's already approved with this biology, and that's TDM1 or Kadcyla, and this allows the chemotherapy to be directed to the cancer cell with the HER2 receptor. We have another drug that was approved just this past month, trastuzumab deruxtecan, and this drug is a similar type of drug-antibody conjugate where trastuzumab is bound to deruxtecan. The studies were reported out at San Antonio in December with dramatic results. This shows of all the individual patients that tumor shrinkage, and what you can see is all but a very small number of patients had a marked decrease in tumor size and dramatic responses with this new agent that was just approved. This approach of a drug-antibody conjugate has now been studied also in triple-negative breast cancer. We've been researching for targets in patients with triple-negative breast cancer, and on the surface of a significant number of triple-negative breast cancers, the TROP1 receptor has been identified. An antibody, trastuzumab, has been developed for that TROP1 receptor, and chemotherapy govitecan has been bound to that. The short name for this is IMU-132. This was also reported out in the New England Journal of Medicine, and as you can see, with a similar plot, many patients responded with triple-negative breast cancer to this new drug-antibody conjugate. A second study is currently ongoing, the ASCENT trial, which compares this drug to standard chemotherapy. And hopefully, if this drug has positive results in that trial, it should become available to our triple-negative breast cancer patients. The big story for triple-negative breast cancers in the last year is immunotherapy. Many other cancer subtypes have had success with immunotherapy, and it's taken a longer time for breast cancer to identify potential options. In other cancer subtypes, single-agent immunotherapy has been effective. What we have learned in breast cancer is that immunotherapy can offer benefit, but in combination with other agents. This report last year demonstrated that when chemotherapy, nab-paclitaxel, was combined with an immunotherapy agent, atezolizumab, there was improved outcome compared to nab-paclitaxel by itself. In this study, patients who had recurrent breast cancer that was triple negative, patients were randomized to the standard nab-paclitaxel with or without immunotherapy. The goal of immunotherapy is to allow the immune system to fight the cancer cells. And what we know is that tumor cells produce substances that suppress or put the immune system to sleep, and this prevents the immune system to play this important role. The group of drugs that accomplish reactivating the immune system are called immune checkpoint inhibitors, and PD-L1 inhibitor atezolizumab was studied in this trial. Here's a staining solution showing PD-L1 uptake on this particular tumor. We've also learned that not all cells have PD-L1 present or have an immune reaction. And in this study, they determined that triple-negative breast cancer can be effectively treated with these drugs if there's an active immune response present. This slide shows that for those patients whose tumor was PD-L1 positive, there was an improved outcome compared to just the single-agent nab-paclitaxel. So atezolizumab has been approved for patients with triple-negative breast cancer with active immunotherapy for patients who are PD-L1 positive. I'd like to follow up. My last area I'd like to discuss is the progress that we've made with hormonal therapy for ER-positive breast cancer. This slide is a summary that was presented at San Antonio of all the different drugs that have been developed to target the breast cancer cells that are hormone receptor positive, and this is what the majority of breast cancers are. One of the challenges for patients and physicians with all these different options is often the question of, do I really need to continue this, or how long should I be on the drug? And these are questions that we often don't have good answers for. There's some exciting new technologies that we hope will address these questions for patients and physicians. And this gets into new detection techniques. We are now able to measure in the blood circulating tumor cells or cell-free DNA that's been released from the tumor cells in the bloodstream. In the past, we had markers CA2729, CA8A, or CA15-3 that we would try to measure in our breast cancer survivors, and these just aren't very sensitive or specific. But circulating tumor cells and circulating tumor DNA are able to detect much smaller amounts in the blood and are much more successful at detecting evidence of breast cancer. Multiple reports were presented at San Antonio and have been published in the last year on using these new techniques to identify recurrences of breast cancer. This study looked at circulating tumor cells and demonstrated that patients who are asymptomatic, who had evidence of circulating tumor cells in their blood, had a recurrence earlier, and those patients that didn't have circulating tumor cells, we did not see those recurrences. This is another study which is also looking at circulating tumor DNA and recurrence risk. And this study was exciting because this study was done after the patients had been on hormonal therapy for several years. So this was addressing the question of, do we need to continue treatment beyond 5 years or 10 years? Now that we have these new techniques, the next range of studies will be to look at, can we influence that result? If we see evidence of circulating tumor cells or tumor DNA in the blood, does that mean we should change our treatment, start a new therapy? And also for our patients where we don't see any signs of recurrence, will that allow us to make a decision to stop therapy sooner? This is just a summary slide of all the different drugs that have been approved for the different subtypes of breast cancer and ongoing research that hopefully will result in new options for our patients within the next few years. I also wanted to show some very positive news. When we look at over the last 3 decades in this country, this is a graph showing the decrease in death rates due to breast cancer over the last few decades. This relates to the research that's been successful both in early detection as well as our new options for therapy. In the same article that reported on this decline in rates, they also showed over the last several years the number of deaths that were prevented with these new techniques and for both detection and treatment. I spent a lot of time trying to develop a slide discussing the current clinical trials at Hopkins, and I realized I couldn't get it on a slide. It's probably a whole talk of itself. But I did want to mention that we have many studies of treatment before therapy, before surgery, neoadjuvant trials, and also several studies which look at treatment afterwards. We have some of those trials are involving immunotherapy and new agents. And for advanced patients, we have the IMAGE-2 trial, which I mentioned earlier, as well as several other new drugs or new types of treatment with current drugs. I want to thank you for listening to our webinar, and I also wanted to specifically thank patients who participated in clinical trials and their families and the support for these efforts. Thank you so much.
Dr. Wilkinson, thank you so much. That was fantastic. I know that I always learn a lot by listening to you talk. Thank you for those of you at home who are sending in questions. We're getting a lot of good questions. Please keep them coming. We'll try to get to as many as possible. To start out, Dr. Wilkinson, we're getting a question about not having a family history. Do you recommend that all patients should speak to a genetic counselor, or if you don't have a family history, you may not be something that you should follow up on?
That's a very good question, and it's a question that's been, the answer has changed with the developments of new therapies. There have been, first of all, the option for testing has become more available because of decrease in terms of the cost. And also, we've learned that with smaller families, that history may not help us determine if somebody's at risk. Recent studies have shown in trying to use guidelines for doing genetic testing that doesn't always detect all the patients that we want to. With our patients who have advanced breast cancer now, we're also looking at doing genetic testing to determine if some of the targeted therapies will be options. So for example, if a patient recurs with their breast cancer, doing genetic testing, we may find a BRCA1 or BRCA2 mutation we may not have known was there, and that would allow us to use some of the new drugs, the PARP inhibitors.
So for patients that you see in your clinic, do you recommend that everybody go to genetics, or does it really vary depending on the situation?
With most patients, we have the conversation, and a lot of times patients will want to go ahead because it would be helpful for other family members, potentially for their daughters. Sometimes children of patients with breast cancer, it's very, very helpful for the children to know so that their treatment is appropriate too.
And I know you mentioned that there's been a definite decrease in cost, which is wonderful. Can you talk a little bit about sort of the process, that if you think someone might benefit from seeing a genetic counselor, what happens after you suggest that?
So there are a couple of different approaches. We have great genetic counselors here at Hopkins, and if patients want to meet with a genetic counselor, we can refer them and they'll have a meeting with the genetics counselor. And most frequently it's simply a saliva swab, a mouth swab that's used to do the testing. Sometimes we do blood. If a patient is where we feel like it would make a difference in terms of care in a very short period of time, then sometimes the clinic staff will go ahead and do the testing so that we can get that information right away. And then depending on those results, sometimes those patients will see the genetic counselor after the testing's been done.
Sure, it makes a lot of sense. And great news to hear that the costs are becoming more affordable for a lot of patients.
Absolutely.
Is this something that insurance typically covers, or does it vary?
So there are guidelines for who's perceived at risk, and in those situations insurance will cover it. But now that the techniques have been developed and it's more affordable, most patients, if the insurance doesn't cover it, the genetics companies will give discounted rates for patients.
It's great to hear. In fact, I heard recently that it was as low as sometimes $250 with
yes.
the out-of-pocket
yes.
expense, which is great news and definitely something that has been moving in the right direction over the last
Yes,
several
absolutely.
years. Good to hear. I was really interested in some of the things you were saying about immunotherapy, and we're getting some questions about that. So can you just remind us again exactly what immunotherapy is and why it's so important to the field of cancer?
So immunotherapy is a way to encourage our own immune systems to fight the breast cancer. As we've learned, many cancer cells are able to shut down the immune system. They release substances that can inhibit the immune system and not fight the cancer. So immunotherapy is a novel way to reactivate the immune system and allow it to help all the other treatments that we're doing to fight the cancer.
Great to hear. So for a patient that has advanced breast cancer, is immunotherapy something that may be considered?
Yes, and there are many trials looking at how to develop effective therapy. So oftentimes there may be an option for participation in a clinical trial. The drug that has been approved as immunotherapy, atezolizumab, is a drug that's been approved for triple-negative breast cancer patients if they have evidence of the immune response, the PD-L1 positivity.
Great. And we're getting a question about PARP inhibitors, and I know you had mentioned that they can be really helpful for patients, especially those who are BRCA positive. Are those the only time that PARP inhibitors are recommended, and are there other genetic mutations that PARP inhibitors might be beneficial for?
That's a great question. There are studies ongoing with the less common types of hereditary mutations with PARP inhibitors, and so we've been enrolling patients at Hopkins on these clinical trials looking at less common mutations to evaluate that.
So would a patient be eligible for a PARP inhibitor if she's not BRCA positive?
Potentially, either in a clinical trial, or we have had experience where the Molecular Tumor Board has thought it would be a good option, and we've been able to get insurance coverage for the PARP inhibitor.
That's great. And it sounds like we'll be hearing more about PARP inhibitors as time goes on.
As the study results come out.
Which is really exciting to hear. I'm getting another question about immunotherapy for someone who's got stage 4 breast cancer. She wants to know why her doctor did not recommend immunotherapy.
So it may be possible that if it was a HER2 positive breast cancer or an estrogen receptor positive breast cancer, it would not be an option for them. Or if it's triple negative and they didn't have PD-L1 positivity, then the physician may have indicated that wasn't an option. There are many clinical trials out there, and so if the patient can't get it as part of standard therapy now, they can look at the clinical trials.
I know you mentioned a lot about clinical trials, and for patients that are being treated at Hopkins, most of them are being screened for clinical trials when we see them, which is great. For patients that may be watching this webinar who are somewhere else or not affiliated with Hopkins, do you have any recommendations about if you're interested in a clinical trial, you want to learn more about what options might be available, where to possibly inquire about that?
That's a really good question, and I think that there's a lot of challenges in terms of looking. Clinicaltrials.gov is the area where there are all clinical trials, and you can look for trials there. There's some other very nice sites which do their best to advise patients about options. There's one for breast cancer in general and one for advanced breast cancer, where you can put in some basic details about your history and where you live, and they can report out options for clinical trials. And I can give you some of those links, and you could
happy to send
provide that.
Sure. And are those websites tend to be pretty up to date? So if they say that a trial is open, can you assume that they are, or is it a lot more complicated than that?
Yeah, I mean, you could find something there, and then you contact them, and things change so quickly.
Sure. Yeah, I definitely understand that. We have a question about Femara. So a patient is wondering that she was taking Femara for 10 years, but somebody else stopped after 5. So what are the recommendations for Femara? Why does one take Femara, and why would it vary between 5 and 10 years?
So that's a question that we're struggling with, and we hope that all the new research that's being done will help us with this question. The partly depends on what the stage of the breast cancer is. So if somebody has a very early stage breast cancer, then 5 years may be all that's required. If it's a higher risk breast cancer with nodal involvement, then the physician may recommend a longer treatment course.
Got it. We're getting a lot of questions about a cancer vaccine, many questions. So for starters, can you tell the audience, is there a breast cancer vaccine that's coming down the pike?
So there's been a lot of research on vaccines, and Dr. Emmons, who was at Hopkins previously, had done a vaccine trial for breast cancer patients. I think that it's a very active area of research. I don't think we have a vaccine here currently, but we're still working on it, is what I would say.
And for someone who might be interested in that, is that going to be something for advanced cancer patients, or is that for early stage, or we're just too early to know?
I think they've looked at it in both scenarios. Yeah.
Okay, so stay tuned is what it sounds like. That hopefully there'll be something down the pike on that. Good to hear. We've got some questions about supplements. I'm sure you see this a lot in your practice. Are there supplements that you recommend patients take, stay away from? What's sort of the party line on that?
I think it's very challenging. I think when my experience has been when patients are diagnosed, friends and families all want to help, and they do research and often encourage patients to initiate supplements. The studies have not been very reassuring in terms of those results, and in the 80s and 90s there were studies looking at vitamins to try to lower risk of recurrence, and in fact there were some data that suggested that taking extra vitamins might increase, not in breast cancer specifically, but in other cancer subtypes. So I think we don't know how to use supplements or vitamins, and the sense is fruits and vegetables are the best sources for our vitamins at this time. There is some data that if our vitamin D levels are low, we should get those up to the therapeutic range. But I don't encourage supplements in general.
You mentioned vitamin D. We got a question about vitamin D a little while ago. So what are the guidelines for vitamin D, and do you recommend patients get that checked and take a supplement if they're not at that threshold?
Yes, I think depending if you measure your vitamin D in the winter versus the summer, there can be huge differences because it's related to sun exposure. So I think you want to be in the range of 30 to 60. Studies demonstrate that if you're higher than that, it can be a negative factor. So you don't want to overdose with the vitamin D.
Mm-hmm. One thing that I hear from patients is that the dermatologist tells them, make sure you cover all areas with sunscreen. Mm-hmm. And then I know when they come to see us in medical oncology, we say, well, a little bit of sun exposure is probably beneficial. So what would you recommend to tell a patient that we want them to get vitamin D naturally?
I think the sunscreen doesn't work that well. So if you're honest any day, you're going to get some vitamin D exposure.
Sure. Yeah. So it sounds like we are encouraging people to get outside for lots of reasons.
Yes.
Get some fresh air.
Yeah.
Very good. You mentioned liquid biopsies. So we're getting some questions about that. Is that standard of care now, and where are we with that?
So I think it's an intense area of research. The liquid tumor biopsy is another term for measuring circulating tumor cells in the blood, and I think outside of the clinical trial, we don't know yet what to do with those results. So in preparing for this talk, I looked at the different studies that are out there, and many of them are still trying to gather data to confirm what that circulating tumor DNA or liquid tumor biopsy tells us. It is exciting that at some centers they are now using that data to add in new treatments. In England, there's a trial where they are measuring circulating tumor cells or liquid circulating tumor DNA, and if those numbers rise, then they randomize the patients to an immunotherapy agent. So I think the future, we're getting close to terms of studying that next question of what intervention would help if we find evidence.
Mm-hmm. No, that makes a lot of sense. We have a question about how does a patient find out if their tumors are PD-L1, and can this be done through a blood biopsy?
So the best way to do PD-L1 testing is on the tumor. So doing a biopsy on the tumor specimen is really the best way to tell. And so just like the pathologist can stain for hormone receptors and HER2 receptors, if a breast cancer is triple negative, we can ask the pathologist to do those special staining.
And is that something that's done routinely, or is that something that the oncologist needs to?
The oncologist would ask, because if it's an early stage breast cancer patient, we wouldn't routinely do it. But if a patient has a recurrence or is diagnosed with stage 4, then that's when we would request it.
Makes sense. You mentioned the term molecular tumor board. So for patients who don't know what that is, can you talk a little bit about what it is, why we do it, how it's done?
Sure. So the molecular tumor boards have been developed. We've always had tumor boards where we would meet as a group to make decisions about local treatment and systemic therapy. But molecular tumor boards address the additional expertise necessary to interpret genetic analysis of tumors. When we send off a biopsy for a gene analysis, we get back multiple pages of reports in terms of what mutations they see and what potential options are available. A molecular tumor board includes generally the physician who's caring for the patient, and then a group of scientists who can look at that list and identify whether there are potential targets that may be available in terms of drugs.
Now, does every patient get seen in a molecular tumor board, or is it a very select?
So in Hopkins, there's the potential for participating in a molecular tumor board if the physician requests it, but most of it is in the context of a clinical research trial, the image trial that I mentioned.
And is that pretty common? Is that a term that's used at other big
Yes.
hospitals, or is that
Yes.
something unique to?
I think it's used at other academic centers when that additional testing is being done. It's a learning process for us all. So having the tumor boards is a way for individuals to get educated and help guide us in terms of options.
You mentioned tumor boards, so you talked a little bit about what a molecular tumor board looks like. Maybe you could tell the audience a little bit about how a tumor board works, not in the molecular sense, but just a standard tumor board.
So most cancer centers will have tumor boards that are disease specific. For breast cancers, as an example, we have the pathologist, the radiologist there who will show the imaging studies, the slides, the x-rays, and then the surgeon, the radiation oncologist, and the medical oncologist will have a discussion about treatment planning, what orders should be considered, whether surgery or chemotherapy, and how radiation could help. And then within that discussion, there'll be multiple medical oncologists to discuss different types of therapy, and the researchers are there to advise on potential clinical trials.
So it sounds like it's a really good opportunity if a patient doesn't sort of meet what we would call the typical sort of trajectory, or if there's some other issues that we need to discuss in a bigger format.
Exactly.
Sounds like it can be very helpful.
Yes.
We have a question about screening and surveillance going forward. So one of my friends had breast cancer, got a bone scan, a CT, and a PET scan. Do you recommend that for a patient with early stage disease, or where do we sort of?
Yeah, so with imaging studies and surveillance, I think I'm expecting this will change within the next decade as we get more information on the potential for blood tests, and potentially that could direct who needs to have those scans. But the problem with imaging studies is that they don't diagnose distant disease. They can see spots or areas. We don't know if it's scar tissue. We don't know if it's been there. We don't know if it's benign. And so if we test somebody, if we tested all our patients with PET scans and CT scans and bone scans, if they're early stage, the odds are much higher that we'll find something that's not related to the cancer. And then we're in a position of, well, do we keep evaluating this? Do we have to do a biopsy? So the guidelines are to do those studies if somebody is at high risk for having cancer spread. So if the lymph nodes are involved, or if somebody's having symptoms that are worrisome. So if somebody has a pain or a cough that persists, then we do directed imaging studies.
But it sounds like it's routine care right now. Hopefully that vaccine or the blood studies will be coming down the pipe at some point.
Yep.
Great. We have a question about foundation medicine. What is it and why is it used?
So foundation medicine is an example of the genomic testing on the tumor. It's one company that does the analysis. The tumor biopsy is sent to the foundation, and then they report back on the genomics, the mutations, what they see on the tumor. And it's used for all different types of tumor, and they will make an attempt to also, when they report out, identify potential targeted treatments that might be options based on those results.
So as an oncologist, if you got a report back from one of these companies, you could then take those results and then determine the best course of treatment? Potentially. Mm-hmm. So why aren't all tumors sent to companies like this?
So if, for example, I think most patients who are triple negative will probably have these studies done to see if there's something more helpful. For estrogen receptor positive breast cancer, there are now specific targeted drugs that we might find with foundation testing. With HER2 positive patients, there's so many options related to HER2, we don't necessarily do the foundation testing because that HER2 target really drives the most effective therapy currently.
Makes sense. We're getting some questions about breast cancer risk of recurrence. I know I spent a lot of time talking to patients about this fear for early stage breast cancer. As a medical oncologist, what do you tell your patients about what they can do to reduce their risk?
You know, it's a great question, and I think it's challenging for patients. They want to do absolutely everything they can to lower their risk, and again, they get advice from all directions on what they should do. Yeah. There are studies that say exercise may be the most important thing. If a patient exercises more, that suppresses inflammation and can help to lower their cancer risk. Obviously, if the tumor is hormone receptor positive, taking the medication as directed is very important. There are studies looking at healthy food and diet, a Mediterranean diet, and exercise are probably the two most important things. There's a lot of discussion about alcohol and breast cancer, more related to whether increased alcohol intake increases our risk of getting breast cancer, not so clear that it increases the risk of recurrence.
And what are those alcohol recommendations?
So they're also all over the page. I think that there are some which would argue that to minimize risk of getting breast cancer, we should abstain from alcohol. Others show that 1 or 2 drinks a week is probably not likely to increase risk. 1 or 2 drinks a day is probably more than you want to do.
Yeah, that makes sense. And in terms of alcohol, I know a cardiologist might say that there might be better types of alcohol than others. Do you have a feeling on that? Or
I think for breast cancer, no difference.
Yeah. And you mentioned healthy eating. So Mediterranean diet, what is that? Can you talk a little bit?
Sure. So I think if you look for cancer in general, there are certain risks for carcinogens in some of our foods. So, for example, red meat is classic. So, limiting red meat, processed meats, and high fiber, high fruit and vegetable are probably the most important thing. People talk about low-fat diet being helpful. It's all over the page there.
Yeah, it feels like every few years it seems to change. It's not.
I like the idea of more exercise. That's very straightforward.
Yeah.
More is better. Yeah. And if you said, and we don't want to guilt people into this, every day you have to meet these guidelines. But if you ask me what's the most important thing, if you can exercise for 30 minutes 5 days a week, that's a huge step. That's a very positive way to fight your cancer.
And it sounds like not just to fight your cancer, but to improve overall health as well as mental health and other health issues as well, right? Yeah. So the exercise recommendations, you said 5 times a week, ideally 30 minutes, is sort of that gold standard for a patient who sort of says, I'm not there. Is it the type of thing that a little bit is better than nothing?
Absolutely. And I think also, as you indicated, mental health, the more exercise we do, the better. And so you start off and just gradually inch up as you can.
I often tell patients, park a little bit further, just walk to the mailbox and try to try to get steps in if nothing else.
Absolutely.
Are there exercises that are contraindicated, or is that more of a physical therapy question?
Yeah, I think that's more of a physical therapy question. You want to do something you enjoy and that you will do.
Yeah, no, I think that actually hits the nail on the head, that if you're sort of dragging yourself out of bed, you're not going to stick with it. It's going to be pretty painful. That's tough. So, Yeah, that's helpful. In terms of diet, you mentioned some things that are potentially to limit, such as certain types of meats and processed foods, etc. What is the feeling on soy? I sort of feel like that's been all over the map. Do you recommend that patients limit soy, or has that been disproven?
I don't. I think that, again, when you look in the lab, you may see some results if you have cells or animal studies where you give supplements of soy, you see changes in cancer growth. But when you look at large population studies in this country and other studies, we don't see an increased risk with soy intake. I wouldn't take soy supplements because you don't know what you're getting. But if you, tofu, those things are fine.
Mm-hmm. So things like soy sauce, tofu, a moderate amount is fine.
Yeah.
I know you mentioned lots of times various clinical trials that were ongoing, and for patients at home who might be interested in clinical trials, what is the process? Can you keep your medical? Yeah, talk about that, and also can you keep your medical oncologist or keep your routine care going while you're on a clinical trial?
Yes, I think that that's a great question. I think that sometimes patients, their primary oncologist knows about a clinical trial, and they will arrange for a referral to us. And in that setting, the research team will review the records and determine if the trial is a good option for the patient. Then when they're seen, they get more information, get a consent form so they can understand what's involved in the study, and then there are usually additional testing that needs to be done. There are what we refer to as eligibility criteria for a study, and those criteria are designed to be sure that the potential intervention is a safe intervention, that it's not too dangerous for the patient. And also, when clinical trials are developed, the goal is to be able to answer a question. And so as much as when we see a new treatment, there's a lot of excitement and everybody wants to be on a trial studying it, in order to really determine that a drug is successful, they want to use a particular subtype, either a subtype in terms of the tumor type or the stage. So that's a consideration in terms of whether a trial is going to be an option for a patient.
Okay. And if a patient decides to go on a clinical trial that may be affiliated with a specific center or a group of centers, is the patient still able to keep her oncologist and keep sort of that?
Yes, and I think that's very important. They often have been with one oncologist for many years, and some studies allow some of the treatment to actually be done closer to home, or to have some of the testing done between visits closer to home.
Now, for patients who might be interested in going on a clinical trial, do they have to worry about possibly getting a placebo, getting no treatment at all?
For most clinical trials that are what we call randomized, where there's two potential treatments, most patients will receive what's considered a standard treatment option, or the standard option plus a new agent. So they may receive a placebo, but they won't be receiving no therapy.
Okay. Can you talk a little bit about what's coming down the pike? So I think there's a lot of really exciting things that you mentioned. Are there things that we should tell people at home, tune into this could be really exciting for prime time?
Yeah, I think the drug antibody conjugates are amazing, and I'm very hopeful that we'll see that within the next year. And I'm not sure what's going to be the next step with immunotherapy. There's so much work being done, but certainly there's going to be more to come there.
Can you talk a little bit more about the conjugates? What does that mean? What is it?
So those are the more we learn about the tumor, and we can direct targeted antibodies and add chemotherapy in, those types of drugs, that gets to that question of personalized medicine, that precision medicine, that if you see a particular substance on the surface of a cancer cell, if there's an antibody that you can attach to that cell with a chemotherapy drug attached, that's a very effective way to treat patients.
And can you assume that the side effects might be reduced if they're targeting just the tumor cell, or we can't necessarily assume that?
The chemotherapy might not be an option if it wasn't attached to that.
Okay.
I think the other future is further subdividing types of breast cancer. When we talk about triple negative, we want to have a better name. We want to know, is it a BRCA1, BRCA2 triple negative, or there are many other subtypes that are undergoing study, and so hopefully within the next 5 years, triple negative will go by the wayside, and we'll have other names that are more specific and enable us to make better treatment decisions.
So that's really interesting. Many years ago, it used to be that you either had triple negative or you had HER2 positive. There were sort of just a few subtypes. So can you talk a little bit about the different categories that might be coming? Or?
Sure. So I think that one particular subtype is that which you see a very active immune system, and so those immunogenic subtype, those patients may respond very well to immunotherapy. And then there are some triple negative breast cancers that don't have hormone receptors, but they have a receptor for the male hormone, for androgen receptors, and so there's studies looking at that particular subtype. So that's the sort of further distinction that we're looking at.
Now, you mentioned in your talk immunotherapy, and we're getting some questions about why immunotherapy is so much further for things like melanoma than it is for things like breast cancer.
It's a good question, because when you look back at certain types of cancer like melanoma and kidney cancer, it always has appeared that the immune system has been so important in terms of taking care of those cancers. So historically, years ago, you would sometimes see spontaneous remissions of melanomas or kidney cancers, and those cancers, clearly the immune system was able to fight back those cancers. And some of the very first immune therapies, interferon, interleukin-2, those worked well for those particular cancer subtypes and did nothing for breast cancer. So part of it is the type of cancer and what kind of interaction it has with the immune system. And Dr. Santa Maria, that's his area of interest, says we have to focus on new ways to activate the immune system in terms of fighting breast cancers, and then we'll be able to use immune therapy more effectively.
So not there yet.
Getting there.
Close. Good to hear.
Yeah.
Does the immune system play a part in every breast cancer?
No, and I think that's what we're learning. And when you look at the subtypes of triple negative, it appears that there's some where it's very, very important, and in others it doesn't seem to be, hasn't shown up.
Okay. All right. Interesting. For some of the other mutations that we hear about, things like CHEK2 and other things, where are we with those in terms of targeting treatments?
I think we're still very much in the research phase.
Okay.
They're not as common, and so it takes much longer to get the information. Even with BRCA1 and BRCA2 mutations, when you look at the studies, the number of patients that we have, it takes much more time to look at those. There are certain types of mutations that can result in many different types of cancer, and with those particular ones, they're called mismatch repair. They're common in colon cancer, but we can sometimes see it in breast cancer. Immune therapy is good for that particular subtype. So that's another example. If we did foundation testing or genomic testing on a tumor and we found evidence of mismatch repair for the breast cancer tumor, then immunotherapy might be an option.
You mentioned genomic testing. Can you talk a little bit about what that is? Is that just a type of what Foundation Medicine does, or
Exactly.
is that different? Okay.
Yeah. So there's overlap when we think about genetic testing. That's more the germline, what we're testing, what somebody's inherited, versus genomic. We think of what's happened within those individual cells, what's developed over time.
Mm-hmm. We had a question a minute ago about someone who did not test positive for any genetic mutations but has a very strong family history and very young breast cancer in her family. What would you recommend in terms of, should this person get additional screening and surveillance, or are we sort of treating her as if she doesn't have no mutation, therefore should be standard of care?
Yeah. That's a great question. And I've asked that question to the genetic counselors, and they've explained it in terms that are beyond my level. So honestly, I think in that setting, that's the sort of patient that a genetic counselor would do very well. We know there are other things we're not testing for currently, and if we can evaluate patients with genetic counselors, and as we get more extensive genetic testing, that should be helpful.
That sounds great. So you mentioned the role of genetic counselors, which I think is incredibly valuable. And we've also talked over the last hour or so that there has there's been a lot of changes in the field of genetics and breast cancer, and it seems like there's more happening all the time. For a patient that has seen a genetic counselor once a few years ago, what do you recommend in terms of follow-up? Does the genetic service call the patient if something has changed, or should that patient be proactive and sort of get back?
I think it's good to be proactive. Yeah. You know, I think that that the companies that do the testing can send back reports when there's a change in evaluating certain results. But I think checking in every few years and just say, particularly if somebody, if a variant was identified and they didn't know how to interpret it, then going back and following up with the counselor would be advisable.
Okay. And is that typically done if a patient wants to go back and speak with them? Do they keep the sample on hand, or is that the type of thing where a patient might have to come back in, give a blood or a saliva sample?
I think it's more that more data from other patients become available, so then they can interpret that patient. So they don't necessarily need to give more tissue. When we only did BRCA1 and 2, which was years and years ago, patients did have to come back now. But now that we're testing so many genes, it's more that we see rare mutations. We don't know what they mean, and so as more patients are tested, the companies may be able to make better decisions about what those results mean.
And you also recommend that families also get involved. So if there is...
Yeah, I think that's very, very helpful. And when a patient's unsure whether they're going to do testing, it's very helpful to have the family come, because it is a family decision, and a patient may be more inclined to do it if the daughters or other family members are eager to know that information.
Switching gears a little bit, we're getting some questions. I know we talked a little bit about vitamin D. Are there other vitamins that patients should sort of be aware of that should be getting tested, or is that the vitamin D sort of...
I think the vitamin D is the one that is that we've learned with our changes in our lifestyle that we are deficient. If a patient has other medical problems, there are certain vitamin levels we might check. If a patient has a neuropathy, then we check vitamin B12 levels to make sure that that's not a consideration. And if somebody has issues with absorption, with GI concerns, where they may not be absorbing certain vitamins, and that would be something that a gastroenterologist would guide a patient about.
So a couple follow-up questions to that. You mentioned neuropathy. For those of us listening at home that don't know what neuropathy is, can you just define that?
Sure. So if numbness or tingling in the fingers and toes, some of our drugs can cause that. And if that happens, it's not unreasonable just to make sure that the vitamin B levels are where they need to be.
Sure. You mentioned a gastroenterologist, and so I guess another question that comes to mind is, where is the role for the primary care doctor in all this? So when you're seeing a patient, you may be very actively involved in her life, but do you consult with the primary care doctor, or do you encourage the patient to make sure that she is still meeting with the primary care doctor?
I think that's a very important question. Many patients go through an intense year or two of therapy and develop a very strong relationship with the clinic that's been treating them, and that connection to the primary care may be disrupted by that. And I've had situations where we've realized that the blood pressure needs to be addressed, the cholesterol needs to be addressed, diabetes needs to be screened, and all those things, getting back to the primary care is very important.
So you're not likely to be looking at things like cholesterol, blood pressure, flu shots. So it sounds like sort of overall health and wellness, again, is really important.
Exactly.
And do you encourage patients to continue to see their primary care doctor when they're in treatment, or is that it's so busy, do you sort of say hold off? And
I think it varies. I think that for patients who are on active treatment for 3 to 6 months, they may not need to see their primary during that time frame. But if somebody's on a maintenance type of treatment, checking in with the primary care at least once a year is a great idea.
You mentioned maintenance drugs, so can you talk a little bit about what those are, why they're prescribed, and how long they typically...
So it depends on the stage of the breast cancer. We have some patients with HER2-positive breast cancer who will take a drug for a year. They may start with chemotherapy and then continue with maintenance drugs. And those patients, after they finish their chemotherapy, would be useful to see the primary care. For patients who have ongoing active disease, they may stay on treatment for many, many years, and that is dependent on a number of factors in terms of how they're tolerating the drugs and how well the drugs are working.
That's really helpful. We have a question about the immune system, and the question is: Is a strong immune system is a strong immune system important for breast cancer survival, and is there a way to measure an immune system?
It's a very difficult question. There are many ways to assess immune function, but today we don't have a test to essentially test the immune system and say yes, it's working well, or no, it's not. We're more right now at the level of, is immune system important in this particular cancer subtype. We do know that certain drugs that suppress the immune system can increase the risk of cancers in general. Patients who've undergone transplants, kidney transplants or heart transplants, take drugs to suppress their immune system to avoid rejection of the donor kidney or donor heart, and unfortunately that immunosuppression may increase the chance that cancers can develop. So the answer is yes, but that it's important, but how to tell if somebody's immune system is intact is difficult.
Sure, not an easy just blood test. A similar question: Are there other diseases associated with cancer, such as autoimmune disorders?
So I think that in terms of genetics, there are certain subtypes of autoimmune disease where you can see cancers develop. For breast cancer, not so much, but for some other cancer types, yes.
Great. Well, we are almost out of time. That went so fast. Are there anything else, any last words or anything else you might want to say that we haven't gotten to in the last hour? You've provided so much information, but is there any final messages that you might want to leave the audience with at home?
No, I just think it's wonderful that everybody is listening and staying focused on their wellness is important. I guess the one other thing I would say, I got a call from a patient's mom today, worried about something she read online, and I think that there's a lot of wealth of information. It's important to go to sites that you can trust, and be sure and share it with your physicians when you have something you're worried about, to put it in context.
Yeah. No, I always say to patients, Google safely. Make sure you're going to the right website.
So, I think that going to the American Cancer Society website, American Cancer Research Institute for Diet and Nutrition is helpful, ACIR. And then I also think if you go to Google Scholar rather than just Dr. Google, Google Scholar is also a good place, because those are peer-reviewed articles. So if you want to try to look at those sites, those are good.
Those are really helpful. Well, thank you so much, and thank you everybody at home. We've gotten a lot of really great questions. If we didn't get to your question in the last hour, I apologize. We've gotten so much interest in this. I appreciate you all joining us, Dr. Wilkinson. Thank you so much for taking the last hour to spend with us. I hope this was helpful for you at home. Just as a final reminder, please click on the evaluation link that you see here. Again, that'll give us feedback of how we did today, as well as help us plan for going forward. This webinar and slides will be available online. In the next few days, I will send out an email. So again, thank you for joining us. A lot of great information, a lot of great slides. Hopefully you can go back and review them. Thank you again.
Thank you.
And thank you at home for joining us.